before the tornadoes and the rainstorm, right? No, no bad weather. Thank you all for coming. Do we have this on the push here? We'd like to welcome all of you. We have two excellent speakers today. Dr. Chhabra has been with us for a very long time. She has given many presentations throughout the community here. And Dr. O'Brien is new to Advocate, and we are very, very excited to have them. They make a great team. And I'd like to introduce you first to Dr. Chhabra. Dr. O'Brien will be speaking afterward. Dr. Chhabra is a transplant nephrologist and medical director of the Kidney Transplant Program at Advocate First Medical Center. She received her Bachelor of Medicine and Surgery from the University of Mumbai. Did I say that right?
Perfect.
Thank you. And in MPH, Masters in Public Health and Epidemiology from the University of Massachusetts. Her residencies and fellowships were completed at Northwestern and Michael Reese, and she has been involved in many research projects and has numerous publications on the topic of nephrology. And she's a wonderful person, heart and soul, and brave. So, thank
high
you for
standards I got to live up
presenting to
to.
us. One of my favorite people, love her.
Thank you, Sue, for getting this together. I appreciate all of you being here. We're a small group. I'm going to try and get through my presentation talking about, kidney disease, a little bit about, what we see, things that you can do to look after your health. If you have a question and you want to interrupt me, please do. If it's going to take a long time, then I can, wait for the end just to keep things going. So I got a very ambitious talk. I'm going to try and cover a lot. I'm going to talk on, like big things, like the practical things, things that I hope will help you, keep an eye on things that might matter to you with regards to, kidney disease, blood tests, and things like that. So, this is kind of like how I've broken up my talk. I'm going to try and talk about, what is chronic kidney disease, the causes, like how do we recognize, how do we diagnose it? And then, of course, a little bit about what we can do to prevent it. But, as we're going along in the talk, you realize, I'll be talking about prevention, kind of at the same time. So, of course, this is like my happy-looking kidneys over here. And then these are the not-so-happy kidneys. So what is chronic kidney disease? So, chronic means something that's lasting a long time. And the truth is very often, like we can have, illnesses. You might get, like an infection, a cough, the flu. Sometimes you might just get dehydrated. And if you do your blood test right away, like your kidney function may not look too good. But then the hope is that you bounce back, once that infection or whatever it is, gets better, and then your kidney function improves. So that's not what we call chronic kidney disease. So this is, kidney disease that's more permanent, that lasts longer. And then for us, if it's a kidney function that's not doing too good, like for at least 3 months, then it kind of like qualifies for, this definition of chronic kidney disease. And it doesn't matter what's causing it. It could be any number of causes causing that kidney failure or, the decreased kidney function, but that all gets pooled into like this mixed bag of chronic kidney disease. So now what are the causes? So, a little overview of, really the kidneys. So we have the two kidneys. Some people may be born with, one kidney or a partially formed kidney. So, there may be like congenital issues. But most often, we have two kidneys. We have these ureters, which are, really our tubing, the plumbing that goes to the bladder. The bladder stores the urine there for a little bit until we're ready, to pee. So now, if you think about it, like anything that can cause issues with not just the kidneys, but even like the plumbing can eventually cause kidney disease and cause, kidney problems. For example, I have the next slide. It's a lot, but don't worry about, what's written in the fine print. All that it is that, you might have diseases of the entire body. For example, high blood pressure, diabetes. So this first column that I have over here, oops, I didn't mean to do that. So this first column that I have over here is actually what we call systemic illnesses. So illnesses that affect your entire system, and unfortunately, they're also affecting the kidneys. For example, high blood pressure, diabetes, it affects everything. And if it's not well controlled, unfortunately, the kidneys can also get affected. We have a few things like drugs. Some people might have, like more serious conditions like cancers that also, affect the kidneys. Things like medications that are easily available over the counter, that if anybody has kidney disease, your doctor will always tell you, stay away from things like ibuprofen, Motrin, Aleve, like all of the easily available over-the-counter pain medications that we have easy access to, especially if you're taking a lot of them in a short amount of time, that can cause kidney trouble. So that is, something that's affecting everything. You might have diseases, and this is, this column over here, that is only kind of like restricted to the kidney. An example is, like there are certain kinds of kidney diseases that might happen after an infection. There are certain conditions that may be genetic, they may not be genetic, that kind of just affect the kidneys alone, but everything else is spared. So we have a whole bunch of things. You have things that can affect the kidneys. You can have things that can affect the ureters and the bladders. Kidney stones, if people have a lot of kidney stones and they tend to form a lot of kidney stones, very often, the kidney stones cause so many problems that it can cause back pressure and then the kidneys don't work too well. Same thing with people who have issues with a bladder. The bladder may not be functioning too well, or there's a lot of urine instead of going downwards, it's actually going backwards. It's something that we call reflux. That can cause kidney disease over time. Prostate issues, if the prostate, is causing an obstruction and preventing the normal flow of urine outwards, then it tends to cause a lot of back pressure and pain, and can affect the kidneys. So we have a whole bunch of stuff. Vascular disease is when the blood vessels are affected. Things like high blood pressure, those affect blood vessels everywhere, including blood vessels in the kidney. The same thing with people who have things like cholesterol that might be up. Sometimes smoking, certain kinds of drugs like cocaine, all of that can cause issues with these blood vessels. So the kidneys don't get enough blood flow. They don't get enough blood supply. It can happen at bigger vessels. Sometimes even the smaller vessels in the kidney get affected, and all of that leads to kidney damage over time. The good thing is that there are some of these conditions, if they're picked up early and they're treated appropriately, they can prevent getting to the point where the kidneys get permanently damaged. So this is a very long list, and the truth is there are lots of things that can cause kidney disease. But to make things simpler, I've picked up some like the big ones. So you got to be careful of diabetes, high blood pressure, kidney inflammation, like some of these diseases that I was talking about. There's a genetic condition which is called polycystic kidney disease. It's not that common, but if people do have it, especially if they have a familial history, very often we tell them, or to have their loved ones get tested too. Any blockages, like I mentioned, the prostate, stones, things like that, and medicines. So now, like what is really the distribution of all of these diseases? So the biggest culprit is diabetes. So about 40 to 45% of all causes of kidney disease is because of diabetes. So you can imagine how important it is. High blood pressure, almost 30%, and then the rest, like cystic disease, that's where, the polycystic kidney disease falls, which could be anywhere from like around 2 to 3% at the most. And then all of the other things, urologic diseases are things that, that affect like the plumbing. So to give you an idea, so 1 in every 3 adults in America has high blood pressure, which is a lot. Now, not everybody develops kidney disease. Out of the people who have high blood pressure, 1 in every 5 develops kidney disease. You have to be careful because, it all depends on how the person is looking after themselves too. If the blood pressure is poorly controlled, it's more likely that that over time is going to cause kidney damage. And if you have DM is diabetes, so if you have diabetes, 1 in every 3 adults, so you can imagine. So that's like a large number of people with diabetes who end up with kidney disease. So it is a big problem, and it is more common than we realize. And the sad thing is that, it all kind of adds up. Like if somebody has high blood pressure and they have diabetes, and this is not one of those cases where, it's simple math. It's not 1 + 1 is 2. Like 1 + 1, can very often be 4 or 5. If it's poorly controlled, that risk of kidney disease is much higher. If you have somebody now who's overweight and obese, the same thing, so it's like obesity, it all kind of connects. If you're overweight, it makes it harder to control your diabetes, makes it harder to control high blood pressure, which ultimately leads to kidney disease. Being overweight itself can cause kidney disease, even if blood pressure and diabetes is under perfect control. So now, how do we recognize it? Are we doing okay so far? Mm-hmm. So how do we recognize kidney disease? So, the few things are, like you have to be aware that, that you may feel fine. Like very early on with kidney disease, like you really don't feel sick. The truth is that all of us, just with age, like, we do lose a little bit of kidney reserve over time. But that's like the normal aging process, it's expected. So, over time, like even if, you go in for routine blood work and the doc says, oh, you have kidney disease. And then the question is, like, is it like my normal, decline in kidney function, or is it something, which is more than what's expected? Very often, it's not just blood tests, but it's also urine tests. Very often, like primary care physicians, like they have, a urine test that they can do in the office that doesn't have to go into a lab. And they can tell you a few things. They can tell you, if there's sugar in the urine. Normally, there shouldn't be sugar in the urine. But if somebody has diabetes, especially if it's not well controlled, you might see it. Sometimes there are medications that can do it. So your doctor will tell you if it's anything like which is expected or not. And then, of course, they can tell you if there are infections and things like that. Very often, like, you might have like kidney disease before you really even have like, tests that may look abnormal. And it's a combination of things. If somebody has, like one kidney, it could be one kidney that they're born with, but kidney function is fine, they still qualify and they're still defined as having chronic kidney disease, even though the blood test may be perfect. Now, of course, everything has like a range. Like I put this up here because this is actually like, what you see on your blood test. So things that you see, like, the numbers that like kind of like give you an idea about what the kidney function is, like the BUN, the creatinine. And then the creatinine is used to calculate a number, which the lab gives you, which is the GFR. And very often, like your docs will tell you, oh, your kidney function is at whatever 50% or 60%. And that is based off this number. So, it's a range. So, the higher the number of the GFR, the better. And to make it easy, like, we have a range of anywhere between 80 to 120. So it's kind of like a percent is normal kidney function. If you're starting off with like a kidney function of around 80, and then, over a few years, you see that decline, then the question is, it's like, how much is it declining? You have like this range. When it gets down to like less than 60, that's when we start to like be a little bit more aware of what's going on. 15 and less, then you already have advanced kidney disease, and then very often we call it, end-stage kidney disease or kidney failure. This is, very often what, like your docs will tell you where you are and what stage is it. So we have people who have kidney dysfunction or kidney function which is reduced. So as you can imagine, like everything has like, a degree of severity. So, how bad is, like bad when I need to be more aggressive in terms of, treating or looking after myself. So they have like, these are the stages based on the GFR. So you have like 1 to 5, 5 being the most severe. So anything above like a 90 for the GFR, we don't worry about it. And then as, it gets more severe, that's when we start to like worry about it. So stage 3 is it's actually like a big group. So, a few years ago, we broke that up into like stage A, 3A and 3B. So you have anybody between like 60 to 30, 30 to 60 over here that we call stage 3 kidney disease. Then you have like the most severe ones. And when we're talking about like kidney function of less than 10 to 15, that's when we start talking about, it's like, how can we help keep them safe? And then Dr. O'Brien will talk about, like the options for the most advanced kidney disease. So that's based on, just that creatinine. Then we found out that, if people have protein that they're spilling in the urine, depending on the amount of protein that they're spilling in the urine, the risk for, like more severe and more serious issues like heart disease is higher. So then they broke things up into, how much of protein is spilling in the urine. The less, the better. If you have somebody who has like more protein and advanced kidney disease, that's, what we call like a more at-risk group. And then the same thing with kidney function. If the kidney function may not be too bad, like, it's mild or like the stage 3A, but they have a lot of protein, then they're at risk for, progression of kidney disease. So then they fall into like a higher risk group. So when your doc is checking things like blood work and urine, this is some of the things that they're watching out for. So what are the early signs? So, very early, so say, okay, now we've kind of established that somebody has kidney disease. Then the question is, like, what should I watch out for? So if you think about it, like the kidney is good at filtering the blood. So it's good at making sure that, that lots of the toxins that the body doesn't need is excreted, and also getting rid of extra fluid that your body doesn't need. If it's not working the way it should, both could happen. These toxins start backing up, and also, the fluid. So you might notice, okay, legs are swelling up, I'm getting short of breath, not too easy to, walk around. Blood pressure might be harder to control. You have to be careful because you also have to make sure that your sugars are doing well. As kidney disease advances, then you see more dramatic changes in the kidney function on the blood test. This creatinine, the protein in the urine, all these toxins backing up, the body doesn't feel too good, nauseous. Very often people say like food doesn't quite taste right. It might taste like a little off, might lose taste. Sometimes things taste like a little metallic. Appetite is not the same. Weakness, getting tired very easily. Some people very early on, all that they might say is just, I'm not sleeping well. Like my sleep is off. I'm not able to sleep. I'm not able to stay asleep. Itching once, things get like even more advanced, muscle cramps, anemia, bone disease. And what's interesting is that with diabetes, because the kidneys do play a role in, like managing insulin, very often, like in diabetes actually starts to look a little better. So people say, oh, I need less insulin. But very often that may not be a good thing. It might be the kidneys which are failing and getting worse. So management. So, so now we have like a little bit of an idea of the background of things. So how do we manage kidney disease? A lot of it is trying to prevent, whatever may have started it in the first place, to prevent it from getting worse, or to control the initial cause of it. For example, high blood pressure. It doesn't matter ultimately like what's caused the kidneys to fail. It could be stones. The truth is, helping your blood pressure be under control prevents that rapid decline in kidney function. So it protects what kidney function you have. Check blood pressure regularly, the correct technique, watch your diet. And all of this, of course, changes as time goes on. Very often the docs say, you're doing fine now. I'm watching things like your potassium, watching things like your phosphorus. And then as the kidney, tends to, like decline further, then they might say, you need to be a little bit more cautious. If you had like X amount of restriction with like, maybe potassium or, salt, sometimes, that gets a little bit more stringent. So that gets a little stricter. Keep yourself as active as you can. That helps. Watching, your medications, taking that on time, not skipping doses. And then, of course, your doc will help you find out what works for you, because not everybody tolerates, the same blood pressure medications or whatever it may be in the same way. So the same thing again, look after diabetes, look after the heart, urinary tract infections, things like prostate and stuff like that, stones, work at, keeping those in check, avoiding those medications. Like, things that like keep coming up, excessive alcohol, avoiding drugs, avoiding smoking, because all of that just adds to, like putting you at risk for, kidney disease and rapid decline in kidney dysfunction. Should I go on to a little bit of prevention? Go ahead.
I have a couple of questions. Now, primary doctor treats us as a hypertension. I mean,
Yes.
they do not go beyond sometimes the potassium and
True.
all these things.
Yes.
And by the time you know it, we are already second stage or third.
That's true.
Beginning of the third stage.
And that's a really good point. Like a lot of it is, I think, like taking ownership of asking questions. Take ownership of your health, take that time. And the hard thing is like, I think from a physician point of view too, there's so much of stress to get things done in like, like 10 or 15 minutes, which is not enough time to, really spend the time to talk to patients and to have you, ask questions. But you're doing the right thing. You're here finding out information for yourself. And a lot of it is also watching your own blood tests. Like look and compare with, what it was maybe, like 6 months ago when you had it last. Like if your creatinine, for example, it's like it's 0.8, but then suddenly
Then also you
it
have
changes.
to remind them sometimes.
That's true. That's true.
They forget even to order that.
That's true. That is very true. Like, watching things like your cholesterol, making sure that a urine test is not done very often. I'm with you. And it's okay to ask. It's okay to ask and request, like, hey, may I check, like my urine test, which is completely all right. And if you ask, I don't think they're going to say no unless you've had something like recently which was fine.
And when do we should know about to see the nephrologist and doctor? When we should find out, or the doctor should tell us, right? Who tells us?
So the doc most often, will tell you. But the truth is, like in the early stages of kidney disease, the primary doctor is more than equipped to manage it. They do the same thing, like high blood pressure, the diabetes control, but it also depends on like the doctor's office and the setup. Some doctor's office, they're excellent at managing, like their own blood sugars, and some doctor's offices use an endocrinologist. It's like let the endocrinologist help me, get the patient's diabetes under good control. So it all depends. It depends on the doctor and like how their clinic works. And then sometimes if you feel like, I may not be getting, as much as I would like, request. I know my kidneys are not too bad now, but is it possible for me to meet with a nephrologist? And then the nephrologist might meet with you once and say, you don't need to come back unless, like these numbers decline or whatever it is. But at least then you have that ability, to have that conversation. Nobody will deny that, Okay. I know, they might say, why are you here? Which is okay, just say, I want to educate
Because
myself. I want to find out more.
Okay, women start with blood pressure high as soon as they become menopause, right? Soon, very soon, like 48, 40, 48. And before the kidney disease comes like at
That's
the
true.
age of 50,
That's
50,
true.
55. And nobody knows till we become.
And that I think for us, like because we see patients, both Dr. O'Brien and I, so we work on the kidney transplant side. And that's a lot of what we see too, that very often, by the time like patients become like advanced kidney disease, like a lot of that change is like we were not told earlier. I did all of my follow-ups, or I was never told how important it is to protect it. And then, like a few years go by, and then by the time, they come back, they're already very sick with, like advanced kidney disease. And I think a lot of it is, like paying attention to like your own blood work, your own urine tests, like being proactive with, checking your blood pressures, the blood sugars. Like it's not always, the best when we see you like that one time, blood pressure may be perfect or might be the opposite. But at home, your blood pressures are probably a better idea of, what your blood pressure is doing. And I think those logs are important.
I just have to tell you one
Please.
thing. Even they forget to order the mammogram and the
That's
PET
true.
smear. Can you imagine them with the kidney thing?
That's true. And a lot of it unfortunately also became like, insurance driven. Like many insurances, then they said that, oh, we don't need mammograms every year in a low risk. So then sometimes, they recommend it like every 2 years. But the truth is, I would say if you can get it every year, it's better to know than not. So like prevention, make sure that, you're doing, whatever you can to make sure you're keeping ahead of, any medical issues. And then of course, use your doctor and the resources that you have, like to really get, that education so that you can ask questions and really be ahead of it. I like this organization, the National Kidney Foundation of Illinois, because the truth is there's so much of information out there. It's hard to know exactly how much to trust, what's reliable. The nice thing is that this organization, it does so much, not only for screening and making sure that they have a lot of networking too. You can call them up and you can say, hey, like I was just diagnosed with kidney disease. Do you have anybody, who can share their experiences? And they do. They have like a whole set of like really like a patient network, providers, and they're able to like direct you. And they really do a lot. Like we are very actively involved with them. I have a few patients too, who ended up like going through the whole process, and now they volunteer with them. So it's really a good organization to reach out to if you need any help. So I'm not going to go through this again, but it's repetitive. And then I think Dr. O'Brien is up. My plug, if you're not signed up to be a organ donor, please do. Dan, you're up.
All right.
Thank you very much. I'm going to stick around if there are questions at the end.
I can introduce Dan.
Yeah.
Great team already, okay? Very considerate of each other. All righty, let me see. Pull that one up. You caught me off guard.
I'm sorry. I
All
realized I was
right.
probably coaching
All
on this
right.
time.
My computer's just slower than my thought process. So Daniel C. O'Brien is a general surgeon affiliated with Advocate Christ Medical Center also. He attended medical school at the Feinberg School of Medicine, Northwestern University, and his residency in general surgery was completed at Indiana University, and his fellowship was in general surgery at Indiana University, so School of Medicine. He is board certified in general surgery, and take it from here.
Yeah. And then I'm relatively new to Chicago. I did my transplant surgery fellowship training in California at UCLA and finished up this summer, and have been here at Advocate Christ down the street for several months. Mostly what I do is surgical management of kidney disease, and folks who have kidney disease that require surgery of one kind or another in general are people who are kind of at the far end of that chronic kidney disease spectrum. They have, stage 4, stage 5, end stage renal disease. And there's different things that we can do surgically to help people out. Some of those things involve getting them ready to undergo dialysis, which is the way that we manage renal failure, kind of as a bridge, hopefully in most instances, to ultimately transplant, where we replace failed kidneys with a new kidney. These are photographs that I think are within our right to show, because they're patients that we operated on and took care of, Dr. Chhabra and I, earlier this year. And these are pictures from a news story that was done about them. These are kind of some local residents, Tony and Tracy, who Tony went into renal failure and ultimately needed a transplant. And his wife wanted to give her kidney to him. Unfortunately, she wasn't a match, and we'll talk a little bit more about what that means. But they were able to be enrolled in a program where there was another couple or pair, in this case, a brother and a sister, who lived in Tucson, Arizona, who had the same circumstances. The sister wanted to donate a kidney to her brother, Frank, here, but they weren't a match. However, Tracy was a match to Frank, and Frank's sister was a match to Tony, and so we traded. We'll talk more about what that means later. But it was a good story.
You can YouTube that probably.
Yeah.
Maybe we can have Megan send it to you.
Yeah.
Maybe, yeah, I can probably send it to you in a link and you can watch it. It's pretty cool.
So the first type of surgical management of kidney failure that we'll talk about is getting people ready to undergo dialysis. A lot of people may have heard about dialysis. What dialysis is basically an artificial means by which we can use basically a machine to reproduce kidney function and keep people going despite the fact that their kidneys may have failed. There are different types of dialysis. There's hemodialysis and peritoneal dialysis. Hemodialysis is a bit more common. It's kind of the classic way that people do dialysis. If anybody knows folks who do dialysis, this is the situation where you go to a dialysis center a couple times a week, and you get hooked up to a machine, and the machine withdraws some of your blood, cleans it out, filters it, returns it. In order to undergo dialysis in this way, you have to have a reliable and durable means of removing and returning that blood, which requires a surgery of one kind or another. And the most basic and in most instances best type of surgery that we can offer for that is the creation of what's called an arteriovenous fistula, which we'll talk more about in a moment. Peritoneal dialysis is the other type of dialysis that people can undergo. It's a different mechanism of recreating the kidney's function with the help of machines. The way that peritoneal dialysis works is we perform a surgery to implant a special catheter into people's abdomens, into the space that kind of encompasses your guts, basically. It's called the peritoneum. And the peritoneum has a lining, and when we fill the peritoneum with saltwater solutions of different kinds, by the act of osmosis and exchange of ions and so forth, the peritoneum acts basically as a filter and filters the blood in the same sort of way that the kidneys do. Peritoneal dialysis is done at home. So instead of having to go to a dialysis center to get dialysis done, you can do it at home, which is a good option for a lot of people. It differs from hemodialysis in that it's something that you have to do every day, and it takes a little longer each session. So the common way that people do peritoneal dialysis, if it works for them, is to do it at night. They go to bed, they hook themselves up to the peritoneal dialysis circuit, they wake up in the morning and they're done. Arteriovenous fistula creation, which again is the way that we accomplish hemodialysis, is pretty simple. Basically, it just involves connecting a vein to an artery. The reason why we have to do this is because, again, we have to establish kind of a conduit through which we can remove blood efficiently so that it can be put into the dialysis machine and filtered, and then also return that blood efficiently. We don't want to access people's arteries, which are high, volume and high velocity blood vessels for that purpose, because we can damage those arteries, and that would be bad. Then you wouldn't get blood delivered to your tissue. And unfortunately, veins, at least the veins that are on the surface of your body, the superficial veins, generally, if kind of left alone, are not adequate to accommodate the volume of flow needed to accomplish dialysis. So the solution is to surgically connect a vein, which is depicted here in blue, to an artery. Usually we do this in somebody's arm. We can do it at a number of levels. This is depicting a fistula kind of in somebody's forearm. Surgically, you just make an incision, you find this vein here, and you connect it to the artery. Once you connect that vein to the artery, the blood flow through the vein, the flux of blood into that vein increases beyond what are normal physiologic levels of venous blood flow through the veins. And that vein dilates, gets bigger, it gets more robust, sort of thicker. We call this arterializing, so that it over time, over the course of a month to 6 weeks, becomes a suitable vessel to do dialysis. And then you can go to dialysis and get your dialysis that way. That's one surgery we do. Peritoneal dialysis, as I mentioned, is somewhat different. This is a little bit of a confusing diagram. It's a picture of kind of the side of a person's torso. So this is maybe their chest up here, their abdomen here, their behind right here. And then this cavity here is that peritoneal cavity. So this would be filled with intestines and so forth. We surgically put this little catheter into the abdomen. It's done with a laparoscopic surgery, so a small operation, where we make a couple of small incisions, use a camera, and have everything projected onto a television screen to insert this catheter, which then is able to deliver fluid into the peritoneum to accomplish the peritoneal lining filtering and then remove that fluid. Very simple surgery. Both types of surgeries that we've described here, the AV fistula creation and dialysis, or peritoneal dialysis catheter insertion surgery, are types of surgery where you come in the morning, you have the surgery, you go home that day. Ideally, and this isn't true in all instances, but ideally, dialysis is a bridge to transplant. Transplant is, again, where you remove, where you replace the kidney function by just replacing the kidney itself. Dialysis kind of accomplishes a lot of what the kidney function does naturally and can kind of keep people going, which is excellent. We wouldn't, we'd be in real trouble without that modality. But transplantation is what we hope to be able to offer, people with kidney failure. Transplantation, first of all, it obviates the need to continue to undergo dialysis. So you don't need to go to your dialysis center 3 times a week anymore, or you don't need to do peritoneal dialysis nightly anymore. You can ideally get back to kind of living a normal life. And it's also the case that transplantation is sort of healthier for people than undergoing dialysis indefinitely. People do better if they reach that point of end-stage renal disease by getting a transplant than just by maintaining themselves on dialysis indefinitely. This is kind of a diagram of what the abdomen looks like after a transplant. These are the 2 main blood vessels that kind of run in through the abdomen, the abdominal aorta here, which branch off into these blood vessels that bring blood into the legs. called the iliac arteries, and then this blue one is the corresponding vein, the vena cava and the iliac veins. Here are the native kidneys. So these are the kidneys that you're born with. They kind of reside in the upper abdomen in the back. We leave those alone when we do a transplant. Your native kidneys just stay put in almost all instances. They're not working real well, obviously, which is why you need a transplant, but they're also not hurting you. And so we let them stay put. And then the new kidney, this one here, gets implanted actually in the pelvis. So we make an incision, usually on the right side here or the left side, and connect the blood vessels of that new kidney to these leg blood vessels, the iliac artery and vein. And then we connect that ureter, which again is that plumbing tubing that conveys urine from the kidney into the bladder directly to the bladder. Kidney transplant surgery can be done in two ways. The more common way is through what's called a deceased donor. And what that means is that somebody who has elected to be an organ donor passes away. And if that person's organs are of good quality, they get allocated to recipients of those organs on the basis of blood type compatibility and a few other factors. We always talk about organ donation as a life-saving intervention that people can do, at the end of their life. And you can, and it truly is, you can really save a number of lives by being an organ donor when you consider the fact that people can donate their heart, they can donate their lungs, they can donate their pancreas, they can donate their kidneys, they can donate their liver. You can save, up to 7 people, through organ donation. We are mostly concerned with the kidneys in our practice, and deceased donor transplants, obviously, an essential part of that. In order to receive a kidney from a deceased donor, you get evaluated for transplant, which can generally start, before you're needing dialysis. It can start kind of when you're at that far stage of chronic kidney disease. Once you're listed for transplant, you wait on a wait list until you kind of creep up towards the top. And then you can get competitive for offered organs from deceased donors. Unfortunately, there aren't enough kidneys available through this mechanism to accommodate a very substantial need for kidney transplants. And for that reason, people wait, generally a period of years, before they're reaching the top of that list. Yeah, please.
On that chart,
Yeah.
it looks to me like the two normal kidneys have the blue vein going to them.
Yeah.
Do they have the red vein?
They do. You can kind of imagine maybe the artery is right behind the blue vein. So yeah, exactly. The normal kidneys have both a vein and an artery. Exactly
So there's
right.
3 things.
Yeah, vein, artery, and then this guy is the ureter. Exactly right. Okay.
So how fast that kidney has to be donated, like within a day or 2 days? Or?
Oh yeah, no, that's a very good question. And it's a little, so the mechanism of organ donation is a miracle in a lot of ways, and it's really kind of come into its own only over the last kind of several decades. And the reason for that is because, and this is, I apologize if this gets a little morbid, the main scenario under which somebody donates an organ is they've died from they've suffered brain death. And what that means is they're no longer alive because they don't have any neurologic function anymore. But to be brain dead means that despite not being alive because you don't have neurologic function, you still have a heartbeat. These are people whose hearts are beating, but they're not alive because they don't have any neurologic function. As long as the heart's beating, it's delivering blood to all of the organs of the body. And so despite being dead, those organs can remain healthy for as long as the heart is beating. And so when somebody passes away in this manner, generally the organ donation procedure takes place several days later, because they're continuing to refuse those organs on kind of having an actual heartbeat.
Like only few of the hospital does or most of the hospital?
So only a few
Like
hospitals.
example, if I die here,
Yeah.
the hospital where they are doing this, is very far.
Yeah, so only a couple of the hospitals in Chicago or in the Chicago area, broadly speaking, use a transplant operation. Yeah, but almost all of them do the donor operation. So the donation operation kind of can happen anywhere. there's a big logistical apparatus in place that facilitates this, but surgeons who are able to do the donor operation can kind of come from far and wide to whatever hospital the organ donation procedure is taking place at. They do the procedure there, and then the organs get shipped to wherever they need to go.
Now, if a person has something like cancer.
Yeah,
Can they get there? It's
a really good question.
Have cancer? Or would
Yeah.
they have-
Yeah, so-
they become someone with cancer?
It's a really good question. It's a little bit of a case by case basis. In general, there are certain types of, illnesses, cancer or otherwise, that make it such that a potential donor won't really be able to donate those organs. There are some types of cancer, that if a donor had those illnesses, we'd probably be very hesitant, to use the organ in a transplant. Other types of cancer, we wouldn't worry about too much. So cancer in general can still donate organs. That's not all cancers are the same in that regard.
How many get successful? Example, you did 10.
Yeah,
All the 10 are getting good results or?
yeah, so far.
Yes, yes.
Yeah, all of our,
Because you know what,
Yeah.
it is interesting, I mean, you guys doing so much favor for the other people and all.
yeah.
We want to know whether it is
Yeah, no,
going
it's
successfully.
a great question. It is a very successful intervention, therapy. It's a very, very successful
Oh, okay,
therapy
then
for.
no problem.
Yeah, and it's a very highly scrutinized intervention as well, and by that I mean, outcomes are monitored and recorded and so forth. And on you want sort of at the national level, you want more than 90% of your transplants to be functioning at the end of the year. And knock on wood, we've been higher than that, lately, but there is a high success rate. Yeah.
Is one of my psychiatric doctor that transplant.
Uh-huh.
And we were thinking like, then his color started getting like bad, but luckily his brothers matched it, so it was.
Yeah.
he survived.
Uh-huh.
That's
Good. Yeah, very good. Living donor transplant is a little different, and that's when, kind of like the photographs we saw at the beginning of my talk, people who are alive can donate kidneys to other people. We're born with 2 kidneys, but most of us only need 1 to be perfectly normal from a kidney health standpoint. And so sometimes, appropriately selected donors can give one of their kidneys to somebody else. Most commonly, this happens, between relations or friends that know one another closely. If somebody, has kidney failure and needs a transplant, it may be the case that a family member or a friend or a colleague will be interested in giving that person one of his or her kidneys. The way that we do this is we evaluate both the donor and the recipient with respect to their, appropriateness for doing this. We want our donors to be people that really won't miss that kidney when it's gone. People that don't have kidney disease of their own, people that don't have lots of chronic medical problems that could predispose to kidney disease later on in life, people who are generally healthy and not going to be overly encumbered by the surgical procedure itself. And then we want them ideally to be a match to their recipient. But as we mentioned, there are some things we can do even if they're not. We can enroll them in programs whereby if there's another couple elsewhere in the country that has the same situation and one couple's donor is a match to the other's recipient and vice versa, we can do a swap. In living donation, the donors undergo a laparoscopic surgery, so kind of a minimally invasive operation that we do with, again, sort of long instruments, small incisions in a television screen. Their kidney gets removed and it immediately gets used in transplant for their recipient, who's usually in the operating room next door. And that donor then goes home the next day. And when you look at the rates of kidney problems among donors later on in life, there's really not a difference between the people who donate a kidney and the population at large. People do just fine as long as we're careful about who we pick as a suitable donor. Living donation is also a great option for recipients of the donated kidney. because it can be done expediently. They don't have to languish on dialysis for long periods of time, like they might in order to receive a deceased donor transplant, owing to that discrepancy between the need for donatable organs and their supply. And then the other advantage is living donor kidneys tend to do very well clinically. They come from healthy people, as we talked about, meaning they're healthy organs. And we think it probably helps that, in general, they get taken out of one person and put directly in the other person instead of getting taken out of one person, put in a box of ice, shipped across the country, whatever it may be, and then used for transplant. So it's a really good option.
So the
Yeah.
incision from the living donor, so it will be in their back.
Yeah, no, that's a good question. So it's actually in the front. It's a couple of small 5mm incisions for the laparoscopic instruments and the camera. And then it's one roughly 8cm incision, which is just needed to get the kidney out. And that incision is usually kind of at the bikini line. Yeah, like a C-section.
Oh.
A little less, smaller.
How large is that kidney?
What's that?
How large is the kidney?
Oh, yeah. Most kidneys are between like 10 and 14 centimeters in length. You can picture that. So kind of like the size of a chicken breast. Yeah.
Because you said it was located towards the
Yeah.
back, that's why I was thinking maybe
Right.
the incision
Yeah.
would be.
It's a good question.
In
So
the
yeah,
back.
you can remove kidneys from the back actually, but it's a bigger incision
Yeah,
than when you do it from the front. So
because it's muscles. and
yeah,
stuff.
exactly right.
I have lots of.
No, please. I mean, no. All right.
Can you tell us what food causes, like what food we should avoid that we can never have to be worried about it? Like, I think citrus food, as somebody said, that like oranges and all that.
Citrus.
Is it
Yeah.
something
So I am not a nephrologist, but I know enough that I think that there are.
And that's a tough one too.
I'll take a crack at it. I
Go
think
like- I just want to avoid it. I don't want to go through it.
I think if you're talking about avoiding foods to avoid causing kidney injury or kidney disease, I think it would be tough to say that there are too many foods that are clearly prone to causing kidney damage. Once you have kidney damage or kidney disease, there are certain foods that are useful to avoid. And then broadly speaking, foods that cause these things that cause kidney disease, like diabetes and high blood pressure, might be useful to avoid. So like high sugar diets can cause
Salt and
diabetes.
sugar.
High salt diets can cause hypertension. But I'm sure there's more to say on it. Yeah.
And that's absolutely true, like it has to be what fits you. Very often I tell patients like, they can do a lot of everything in moderation, but they have to be careful. And the issue is also like, where in that whole spectrum of whatever disease you are, if the doc is really having a hard time getting your blood pressure under control, then anything that you can do to help helps. Like, cutting out that extra salt, the fried foods, with diabetes, the same thing. If you're really struggling with, getting your sugars under control, then anything that you can do to cut out, those extra carbs, watch those concentrated sweets, like it really makes such a difference for that diabetes control and for all of that permanent damage that happens, over time. And not just the kidneys, like it's the eyes, the heart, the brain, because of the risk of stroke and things like that. It makes a big difference.
Where do we go to, or where can I go to figure out the content, potassium content, or whatever of various fruits, vegetables, and all of that? Is there a good box? I follow the boxes,
That's-
ingredients, most of the time potassium isn't there.
For whatever
I'm
it's
new to this.
worth, I know that there
The
are,
culinary
like there are even
factor.
some of my friends, like they have like lots of like these digital aids, there are like these little apps on the phone.
Well,
Some
what
of,
are they?
I'll have to find out for you. I know there are lots of not lots, there are a couple of my friends who are also very picky about portion sizes. Then they enter everything, like into the app.
What the daily value
and
is
then
of
of course,
certain
Like
things.
these aids only help as much as you allow it to help, right? Like if you're cheating and not following, like what the recommendations are, then it's hard to, stay on track. But they do use it as a guide as, I can only have like, say, one slice of pizza, and not do, more. They also have these little weighing scales, depending on, how strict, those little weighing scales that you can actually weigh your plate, see like how much of a portion is okay, what the calorie count would be, what the carb count, depending on, what you're eating. And those, I know it would be hard for me to follow that, but I know that many of, my friends and patients say that, this is what works for me. Like, it helps me keep on track. Like even with monitoring, like, things like sugars, like, those little like sensors that are tracking the sugars all of the time and giving you a little alert when, the sugars are high or low. Like even those aids do help patients, stay on track.
I'm diabetic, so I'm used to
You
the
know,
sugar.
That's right.
Yeah.
And it
But I
makes it hard.
need help with the calcium, not
Mhm.
calcium, potassium, and the other content. And what is the best things for me to be
You should go
eating?
to a dietitian.
I was
went
going to
to
say,
two dietitians, and I thought,
yes.
it's really, this is not really a special, more diabetic.
We'll go to a dietitian.
I went to a diabetic, and they
I
were
see.
familiar with the
I see.
potassium and nephrology and whatever.
Yeah,
They tell you
It's-
where they were.
yeah, it's one of those things. Diet is it certainly plays a role in all these chronic illnesses. And I think we probably know more about what's important to avoid once you have these illnesses, chronic kidney disease of one form or another, than we do about kind of what predisposes to it, other than the diabetes and hypertension component. Citrus was mentioned. Correct me if I'm wrong, but I think citrus is fine.
Yes.
Yeah, you don't have to avoid citrus. Yeah, citrus is good.
Just don't eat a lot of it.
Yeah,
Yeah, that's my problem too.
Like the citrus does have some potassium in it. You gotta be careful of the potassium, like the oranges,
Yeah.
like the citrus fruit does have potassium, so you gotta watch out.
Yeah.
That's
true. Yeah.
I don't even know what you said. I don't know. It's just, how long is the recuperation on a,
Yeah, so in general, people who undergo a kidney transplant, they're in the hospital for a couple of days, 4 days to 7 days is pretty typical. And then afterwards, they go home. They're home and should be kind of feeling a little worn out from undergoing a major surgery, but they should be in good shape by the
limited
time they get out of home.
diet at that point, though, right?
Normal diet.
Normal
Normal diet, yeah. And then they ought to be feeling pretty much back to themselves by about 3 months. Pretty typical. The living donors, they go home from the hospital the day after their operation. And they'll have kind of normal post-operative pain, things like that. If you've had your gallbladder out or you've had an appendectomy, that sort of thing. But they ought to be feeling pretty much back to themselves even sooner. The only other thing I'll mention about living donors is, kind of like I said before, the vast majority of the time, a living donor is somebody that's close to the recipient in one way or another, family member, friend, something like that. But every now and then we do a living donation transplant facilitated by a person who we call an altruistic donor. And these are people who just decide that they want to donate one of their kidneys. And it doesn't have to go to someone that they know, it just needs to go to somebody in need. And they get in touch with us, we evaluate them as a potential donor and find a match. And it's a pretty amazing thing to do. You wouldn't expect everybody to do it, but it's a cool thing to be a part of when it does happen. That's kind of it for my talk. A little bit less ambitious than
No,
Dr.
that's
Chhabra.
awesome.
Yeah. You guys have any additional questions?
I got one.
Yeah.
Since I'm receiving chemo,
Yeah.
once I start dialysis, how much of that chemo is gonna be filtered out? Is it gonna affect my treatment?
I can take that. So, it depends. Like, and very often what happens is that, like the entire cancer team, whoever is, kind of ordering and taking care of the chemo, like they coordinate with the nephrologist and maybe even the dialysis. And sometimes, depending on, like they change and they tailor, the kind of chemotherapy they use and the timing. Like they'll say that, hey, it's like this needs to be done, after dialysis. Make sure that it's not done before because I'm worried that, the dialysis will clean it out, so to speak, and it won't be as effective. So it all depends. It all depends. So, sometimes there are certain medications, chemo included, that, that dialysis doesn't affect it. So they may say that they don't need to change anything at all. And then sometimes it's the doses, they might adjust it based on, what they need if you're on dialysis. But they'll be able to coordinate that, especially with, your dialysis and immunotherapy. Make sure that's okay.
Any other questions?
You mentioned, in before,
Yes.
what can you take?
So the truth is Tylenol is the safest. And then if you do not have any kidney disease, like even ibuprofen and Motrin, like especially if you're doing like, one-time dose and you're not doing it too often, and if you're allowed to hydrate, you don't have any fluid restrictions, I would say hydrate when you take that medication too, because it just helps cure it out from your system.
So my doctor told me that I can take Tylenol, and I looked it up, and it affects the liver, so do I have a
Exactly.
choice now?
But for Tylenol to affect the liver, like it's usually a lot of Tylenol.
Yeah, Tylenol is extremely
It's on the
safe.
box. It's on the back of the box.
Exactly.
I
There's
read
there's nothing
everything.
that's safe, that's
It's
true.
on the back of the box. It tells you.
Yeah, it's extremely safe for the liver as long as you
As
don't.
long as you don't take
That's
more
true.
than 4,000
Yeah,
milligrams. I
exactly.
remember that because
Yes.
I worry about my mom taking Tylenol.
Yeah.
So I'm not giving it to her that
That's
often,
true.
and I'm not double dosing her.
And
You're not getting 1,000 milligrams, mom.
And the only time they actually tell you to avoid Tylenol if you can completely is when somebody has like advanced liver disease, to the point where, they're just not able to process it. But otherwise, like the little bit that, an average person takes now and then for aches and pains is completely okay. So that's not, usually not a problem at all. I know, but very true. Very often you have to pick your poison, right? Nothing is safe.
Yeah.
Like,
Yeah,
like even with the fruit, since you mentioned the pineapple and things like that, the hard thing is that, very
I don't
often,
know where to go to check.
very often, like they're gonna say, it's like,
What are
fruit
the
is good for you, but the sugars are not good for you.
No, and the other things that are in there. but
Exactly,
find a balance.
exactly, you do have to
That's
find
all
that
of those
balance.
things.
That's true. That's true.
You think for season, is that how you say it?
Acetaminophen, yes.
Help save it.
Are you talking Tylenol or are you talking something
No, I'm
else?
talking about this new drug that's out, I can't pronounce it. Paracetam, I can't think of the word.
What is it for? What is it
It's
used for?
to take the sugar out of your.
Okay,
What is the?
Farxiga, maybe
Yeah,
Farxiga,
yeah.
yes.
Is that a good drug or what are
You
the
know,
side effects?
It
What's it for?
is. So like with anything, like really it depends on, what works for you. The truth is, like Farxiga, which has been out now for a couple of years, like, I think as we're getting more and more information, we're still learning about it. Like we found that there are so many beneficial effects. It seems to be good, not just for the sugars, it seems to be good for the heart. Very early on, but it seems to be very good for the kidneys too. But it all depends on, like what works for you. Like I have a patient who started on something similar to that, but they were so nauseous, they said, this is not helping me. I feel more sick than, like it's worth. So then they decided not to, but it seems to be a really good drug. And then, if it's something that, that your doc thinks might work for you, ask why. And, you'll hear probably the same things.
My doctor said, the only thing that he's noticed is that people get more UTIs. Is that?
That's true. That is true. And then sometimes, depending on how bad of an issue it is, very often, it's like they may need to stop it. And the reason why is because like the way the drug works, it kind of gets rid of the sugars from your body, but through the urine. But then sugars are also like a good, like the really like a good resource for bacteria. So, the bacteria thrive, and that's why, it does make you more prone to infection.
You've been infected in other parts of your body?
So that's the most common that they saw. But the truth is that if you have diabetes that's not well controlled, that what probably puts you at risk for more infection anyway. So it's probably better to get your diabetes under control to prevent, that bigger risk of infection. So it all depends, on how bad those UTIs are.
Oh, what do you think of Jardiance? Is there anything for that? What's that?
Also good, also a good.
What is that?
Good drug. Very similar to Farxiga. Different companies, but yes, they all have the same good effects.
Did you get UTIs with
Yes,
this one also?
yes, we do.
And both of that. So increasing your water intake or something, that should help a little bit. I mean, provided you don't have any.
Exactly, like, like heart
failure
disease
or
and things
something
like that, but yes.
To help flush it out.
Yes,
Just to help
yes.
flush it out.
And then like with anything, like, in moderation, because sometimes, there is something called like water intoxication too,
Yes.
that, that you're drinking so much in such small amount of time, that, that it's actually negatively affecting you rather than helping you. But yes, for the most part, I tell patients that, that water is good. And then we see patients also, after, like they get a transplant, and at that time, they need to hydrate, keep their kidney transplant healthy. So it's a little different, compared to when, somebody might be struggling with, kidney disease and not able to get rid of the water that the body needs to get rid of. So then it's a little different. Then people might say that, hey, water was good, but now, the kidneys have declined, need to cut back.
So speaking of water, and not in relation to somebody with kidney issues, what is the normal amount of water people should be drinking per day? I see so many different.
The truth is there is no number.
3 liters, I'm thinking 3
You know,
liters is a lot.
The truth is that there is no number, but the question is like the one who's drinking like, that gallon of water, how much are they exercising, right? If it's somebody like my
Right.
son who's like in the gym all the time, like
That's
sweating
true.
gallons, like he needs to keep up with it. It really all depends on how much they're doing, the weather, how active they are. Sometimes medications, sugars, if the sugars are not
So
well
it's
controlled, it
very
can dehydrate
relevant
you.
to your
It really
situation.
is. It really depends on what works for you, which is why if you're not too sure, like, come up with like kind of like, a ballpark with your doctor, how much should I be drinking? And then, at your follow-up, discuss, this is working for me, this is not working for me. And then sometimes it's not just that water, like if you're having something like kidney disease or, heart disease that you're going through, people are very sensitive to like, excess water, sometimes extra salt, depending on their diet. And then sometimes that, like tips them over into, congestive heart failure. So sometimes, that balance is like probably more important for some than others.
Talk to your doctor.
Talk to your doctor. I know.
Thank you very, very much.
Thank you very much.
Always a
Thank
lot of
you.
information.
Thank you.
Thank you.
Appreciate it.
I
Thank
do want to let
Thank you.
everybody, is it okay to put on YouTube Dr. Brian and Dr. Chhabra?
Sure.
We're good with that?
Okay.
So-
Yes, that's right. I'll brag about it.
So just so you know, these presentations are on YouTube, so I know it's a lot to take in at one time. You can go back to the Oakland Public Library website.